Hello from the United States. My name is Jon B. Suzuki. I'm proud to share with you my viewpoints and discussions on osteoporosis and other medications treating osteoporosis that directly impact on dentistry and dental implants and periodontal diseases. As a brief background, I have served in the Food and Drug Administration in the United States, specifically on the Immunological Devices Panel and Dental Products. I've also served on the American Dental Association Council of Scientific Affairs as the chairperson, and also other councils within the American Dental Association in the United States, including the annual sessions and also other councils like the Commission on Dental Accreditation. In addition, I also hold other positions within organizations dealing with dental implants, such as former president of the International Congress of Oral Implantology, and I will show you some of the other features of my academic profile in just a few minutes. This topic, osteoporosis and implications for implant dentistry, will be divided into two parts. Part one is today. Part two will be at another point in time. So in part one, I will discuss risk factors for osteoporosis. I will be able to understand and teach you how the international diagnostic scales for osteoporosis and osteopenia are conducted, and you will be able to understand the osteoporosis and how it impacts on periodontitis and dental implants. Part two of these webinars will deal more with the treatment for osteoporosis by our colleagues in medicine. Mostly, they will be taking anti-resorptive factors, including the drugs bisphosphonates. There is a very, very clear-cut impact of bisphosphonates on dental invasive procedures, including dental implants and other surgical and extraction procedures. You will also be able to incorporate preventive dental approaches to reduce the risk for osteoporosis and osteonecrosis of the jaw, and you'll be able to incorporate these therapies in your dental practices. The BioRes, the implant system, is brilliant and resilient. It is state-of-the-art. It is US-driven with a global reach worldwide. In particular, the system has a very unique precision manufacturing machining center. In addition, there is excellent supply chain support and localized advantages to production of the BSM, Bismile implant, in China. These are sandblasted large grid acid etch illustrations of the BSM BioRes implant system. The various diameters and lengths are shown here. They come in a variety of 3.7, 4.0, 4.5, and 5.0 diameters with different varying lengths, as you can see in this slide, for the BioRes implant type specifications. So let's begin our discussion on osteoporosis and osteonecrosis of the jaw. I appreciate BioRes BLC implant system for sponsoring today's webinar, part one on osteoporosis and bisphosphonates and the impact on dentistry. I might also add that I currently serve as the chairman of the BioRes BSM Dental Board, and we had our meeting last evening in Bellevue, Washington, in the United States, together with Professor Hai Zhang, currently of the University of Texas, San Antonio, chairman of comprehensive dentistry. So we met and we discussed future initiatives of the BioRes dental board systems. So with respect to the implant system and the BioRes implant features, I'd like to indicate, in addition to the precision manufacturing, the applications to private practice and the very broad outreach, both locally and internationally, of this particular implant. I hold different faculty appointments, as shown in this slide, in the United States. I serve as a clinical professor at the University of Maryland in Baltimore, Maryland. I serve as clinical professor at the University of Washington in Seattle, Washington. I serve as clinical professor at Nova Southeastern University in Fort Lauderdale, Florida, and I am currently professor emeritus at Temple University in Philadelphia, Pennsylvania, also in the US. I'm proud to share with you that I'm currently the chairman and the immediate past president of a relatively large and broad dental organization featured primarily in Asia. It's called the International Academy of Contemporary Dentistry, and we have held world congresses annually for the last several years since in 2017. Our most recent World Congress was at the University of Texas in San Antonio in the United States, held just a few months ago. I'd like to share with you some of the previous highlights of our World Congresses, especially conducted in China. At the Kowloon Shangri-La Hotel in Hong Kong in 2017 was our first launch of our institution and our organization and this meeting. This is our current board of directors as initiated at the Hong Kong meeting, and I was speaking in the podium lecturing on dental implants and complications of dental implant surgery. And this is the board that largely from China, from Japan, from Taiwan, and from other countries in Asia. At the Hong Kong meeting, I also had the opportunity to have dinner with Dean Thomas Fleming, Dean of the Faculty of Dentistry at the University of Hong Kong, and he has served as dean for many years at the Faculty of Dentistry at University of Hong Kong and has recently retired. Our other congresses were in Harbin, and in Harbin, China, we held specifically congresses and topics on digital dentistry and impact with dental implants. In particular, I lectured frequently on this particular topic. I'm proud to say that we are in a new age of digital and electronics, and with this high technology, making the delivery of dental implants much more successful to our patients. Another World Congress in 2018 was in Shanghai. At this IACD World Congress, I lectured on complications and evolution of dental implants throughout the ages and how it impacts on adolescents, young adults, and in adults as we age with the medical complications of dental implant surgery. So in Shanghai, I'd like to present to you our IACD Board of Directors selected from China, from Taiwan, from Japan, from Singapore, and from Hong Kong. And this one was supported by the 9th People's Hospital in Shanghai for our Shanghai Dental Congress. So I'm proud to serve as the president at that time at the Shanghai meeting. 60 days before COVID pandemic hit the world, beginning in Wuhan, China, and then going to the United States and worldwide. 60 days before that outbreak, our last World Congress in China was held in Qingdao. Qingdao, a very beautiful city, brought 1,400 doctors to our Congress, and I lectured specifically on peri-implantitis and the reasons why dental implants fail. I happen to be sitting in the front row with the other officers of the IACD in Qingdao. The entire group picture, as shown here in Qingdao, I also sat in the front row, in particular next to the Dean of the University of Texas and other academic leaders in China. We also lectured to the other groups within China in particular, and I'm proud to say I think our remarks were very, very carefully accepted. We had a World Congress again in Honolulu, Hawaii, because it was close to Asia. This IACD World Congress was the first year I actually served as the chairman of the IACD. I also indicated very clearly that we welcomed doctors from China, Japan, Taiwan, Hong Kong, and all of Asia. And in particular, we also invited dental hygienists to this particular World Congress. Our congresses are not only all lectures. We do have various social components, such as this Hawaiian luau dinner in the United States in Hawaii, in particular at a restaurant on Waikiki Beach in Hawaii. But our topic focuses on osteoporosis and implications for implant dentistry. So let's now take a look first at why is this seminar important to dentists. This topic is important to dentists because osteoporosis and osteopenia impacts tremendously on implant and periodontal health, the core of our patients. Our patients who are diagnosed with osteoporosis and osteopenia take different medications, including the bisphosphonates used to treat osteoporosis, and these medications may have a potential adverse reaction to dental invasive procedures, including dental implants. Also, the maintenance of healthy implants may be impacted by patients with osteoporosis and taking these medications. In particular, why is the seminar on osteoporosis and osteonecrosis of the jaw so important to dentists in China? If we take a look at the 5 major risk factors for osteoporosis worldwide, we can see the risk factors are age. The older the patient, the higher the risk. In China and other Asian countries are known to have a very long lifespan. Number 2, race. Caucasians and Asians have a higher risk of these conditions. Number 3, weight. Lightweight and small-boned individuals have an increased risk, and the majority of Chinese citizens are, in fact, lighter than normal citizens in the world. Family, hereditary patterns are also very distinctly clear in China, knowing that relatives, mothers, aunts, grandmothers, if they have osteoporosis, it's clear that the daughters and granddaughters and other grandchildren will have osteoporosis too. Lifestyle, smoking is still level in China, but many Chinese still smoke. This adds to the risk. Lack of exercise for those Chinese that don't exercise regularly, and also alcohol increases the risk. So once again, why is this seminar on osteoporosis and osteonecrosis of the jaw important to dentists in China? Well, in China, 4 of these 5 major risk factors are very, very apparent to the patients in China. So why is this seminar in particular? By the age of 40 or 40 years or older, worldwide osteoporosis is significant, especially in women. A 2021 study reported a prevalence of 5.0 in men and 20.6% for females as young as age 40. The prevalence, 56 were diagnosed with osteopenia, about 45% were diagnosed for osteoporosis, and 65% for females. Calcium deficiency is also clearly related to osteoporosis. 90% of Asians, especially in Asian Americans, are lactose intolerant. Therefore, Asians primarily avoid dairy products, the primary source of calcium in the diet. Calcium is essential for building and maintaining a healthy skeleton. These are the data. They are very clear-cut, they are recent, and it illustrates how important an understanding of osteoporosis and osteonecrosis of the jaw is to dentists practicing and seeing patients in China. Let's take a look at an introduction of what osteoporosis is. Why is an understanding of osteoporosis so important? Why is osteoporosis very quickly diagnosed by our colleagues in medicine? And our colleagues in medicine, the physicians in China, react very quickly and try to have patients treated as quickly as possible. The reasons for the significance of osteoporosis and hip fractures was published by the National Institutes of Health in the United States. 1 out of 4 patients will die from a hip fracture within 1 year after sustaining a hip fracture. 50%, or 1 out of 2 patients, will die within 5 years of sustaining a hip fracture. These are very sobering data and illustrate the importance of the diagnosis of osteoporosis in a physician's office. Let's take a look at what a punch biopsy looks like of a scanning electron microscopy of an iliac crest of a patient. A healthy patient, generally someone in their 20s or 30s, a punch biopsy and submitted to scanning electron microscopy shows a regularly intact bone with different cortical plates. However, on the right, osteoporosis bone is very, very sparse in trabeculi, thinner in terms of cortical crest. So you can see the major differences in the osteoporosis bone, the weakening of the bone shown on the right compared to the left. According to data, at least published in the United States, huge numbers of patients, over 5,000 patients investigated, looking at the prevalence of osteoporosis and osteopenia. 13 to 18% of women over 45 years of age have osteopenia, and 47 to 50% of women over age 45 have osteoporosis. Systemic osteoporosis is also associated with mandibular osteoporosis. So if the diagnosis is made of osteoporosis in the skeletal bones or the spine, which routinely is, you can assume that the mandible is also impacted by osteoporosis. Osteoporosis is in fact associated with increased tooth loss because the loss of supporting structures around the dentition. But what we also know is that with increasing age, the risk and the severity of osteoporosis becomes worse. In particular, once again, it's very important for a dentist to realize the impact of osteoporosis on his dental practice. These are examples of patients with osteoporosis. All of these patients have accelerated bone loss and enhanced tooth loss and loss of bone around the dentition, primarily because osteoporotic bone is not as strong and is not as intact as regular normal bone. I'd like to show you 3 patients in my practices to illustrate the case reports of what patients do with anti-resorptive medications and what the impact on dentistry is. So we will cover in greater detail these medications in part 2, but let's take a look at how these medications directly impact on our patients. In 2006, I published the very first article illustrating osteonecrosis of the jaw from a periodontal surgical procedure. This article and this case report of my patient with osteonecrosis of the jaw was published as the cover story of the Journal of the American Dental Association. What I showed is a 78-year-old white female patient that needed an endodontic treatment on the lower right teeth. This patient had been on a bisphosphonate drug once per day for the last several years, and she was missing teeth. Restorative and other maintenance procedures were conducted every 6 months. Her oral image, she wanted to save all her teeth. The endodontic lesion was on teeth 4, 6, and she needed the treatment as soon as possible because she was in pain. I performed a crown lengthening surgery also on the endodontically treated tooth 4, 6 so that the restoration can be completed. So in particular, this was a complex patient requiring multiple disciplines of dentistry. I performed the crown lengthening surgery, and this is what the patient appeared 3 weeks later during the post-op sequelae. The patient had an abscess, purulence, and was febrile at 38 degrees centigrade. Osseous bone loss was clearly depicted on the x-rays surrounding this particular surgical site, as illustrated here. The patient came in for a second periodontal surgery from me because I had to remove sequestrum of bone appearing like this from the surgical site. I removed the sequestrum of bone like this, and I proceeded to perform different holes in the alveolar structure. And these particular holes in the structure are called regional accelerated phenomenon. The aim was to produce bleeding and to secure a good vascularity and pathway for wound healing cells to populate the site of the osteonecrosis of the jaw. I also put the patient on antibiotics, systemic antibiotics, 500 milligrams of amoxicillin for 21 days, plus a chlorhexidine mouth rinse twice per day for the next 2 to 3 weeks. Fortunately, the patient healed. This is a post-op image of the 3-week post-op after the second surgery. The patient was still continuing on the amoxicillin for the 21 days. The second patient was similar, also on oral anti-resorptive medications, a 67-year-old white female patient whose chief complaint was to save all her teeth. The diagnosis medically was osteoporosis, as the last patient, and this patient was also on oral bisphosphonate drugs. The dental history was that she had restorative and the diagnosis of moderate stage periodontitis. The surgical treatment plan was APF with osseous surgery on the lower right quadrant. I performed the surgery, and once again, this patient resulted in osteonecrosis of the jaw, as seen here during the post-op appointments at 1 week and again at 3 weeks. The patient was in pain. The patient was febrile at 338 degrees centigrade and also exhibited submandibular lymphadenopathy. Case report C is slightly different and more advanced. This patient was also diagnosed with osteoporosis, but this patient had not only oral bisphosphonate drugs, but her physician changed her to IV bisphosphonate drugs called Reclast for the past 2 years. An oral and maxillofacial surgeon extracted several of her teeth, and I performed periodontal treatment on this particular patient, and it resulted in osteonecrosis of the jaw. So these 3 case reports illustrate what dental therapies can do on osteoporosis patients taking a bisphosphonate drug. In part 1 of this seminar, I will explain what the biological basis is for bisphosphonates and the potential adverse dental outcomes. I will also give you recommendations on the proposed management as illustrated in the Journal of the American Dental Association article that I published, and also I will give you dental management preventive strategies for osteoporosis patients seeing in your offices. Fortunately, at least in the United States and around the world, our colleagues in medicine are being educated as to the possible dental impact on their medical practices. That osteonecrosis of the jaw is an area of exposed bone that does not heal, but physicians now worldwide are being educated on the dental outcomes of bisphosphonate medicine and medications on impact on osteoporosis patients. There are very, very meaningful, successful BioRes implants on patients with osteoporosis risk factors. I'd like to show you some examples of these successful BioRes implant patients in patients that are risk factors with osteoporosis. This male patient, 69 years of age, and treated in the premolar region as shown here. The BioRes BLC implant system was placed, as illustrated here, and immediately post-op, these radiographs were taken. This patient was followed for 4 years. 4 years post-op, these dental implants, BioRes implants, are successfully maintained and continue to function very, very well for the patient. Another successful BioRes implants in patients with osteoporosis risk factors is seen in this 52-year-old female patient. And in this molar region on the lower left, in the area of 3/6, we realized that osteoporotic females are at risk for accelerated alveolar bone loss, including that of dental implants. And in this particular patient with these risk factors and with periodontitis, it also shows immediately post-op the successful surgical placement of a BioRes implant. 4 years later, the implants were sound and maintaining very well in function. Last patient is going to be the most complex that I'll show in a 64-year-old Asian male patient with very high risk factors for osteoporosis. This is an all-on-X patient with implant prostheses, and you can take a look at the all-on-X prostheses, very, very successfully placed in the edentulous case. So even in complex stages, this particular high-risk patient has very successful BioRes implants. But let's take a look at the condition of osteoporosis. Why is this particular condition so important to not only our dental and medical profession, but also to our patients? We've already gone over these 5 major risk factors for osteoporosis. However, just a few weeks ago, this particular list of risk factors was updated by the Osteoporosis Foundation. What is added to the risk factors for osteoporosis are men with low testosterone levels have an elevated risk for osteoporosis, and a newer trend for weight loss is patients who have undergone bariatric surgery also are at increased risk for osteoporosis. I won't have time to go into the numerous other factors that have been investigated that affect bone remodeling, but take a look at this list and you can see that the very, very careful orchestration of bone metabolism is altered by different types, different activities, different diets, different history, different medications, and also different diseases. So it's interesting to take these into consideration as well, including diurnal activity of the sun, exposure to sunlight, and also calcium and vitamin D uptake. I published an article for the World Health Organization in London, and it illustrates the biological basis of the hemostasis of bone. We all know that there's a very careful balance between osteoblasts that forms bone, and a very careful orchestration of osteoclasts take down bone. But together, osteoblasts and osteoclasts together undergo very extensive bone remodeling, where the precursor osteoid is mineralized and then forms mature bone. So in taking a look at this artist sketch, you can see the very careful balance between osteoblasts and osteoclasts to maintain optimum bone homeostasis. The quality of bone does have a major impact on dental implants, and it's important to know the particular starting point of your patients and what type of bone they have before surgical placement of any dental implants, including BioRes implants. For example, in these research studies published relatively recently, if dental implants were surgically placed in patients with increased risk of 60% cancellous bone, consistent with D1, D2 bone, the loss of marginal bone is relatively minimal. At 1 year, 0.74 millimeters. However, at 3 to 4 years of bone, the bone loss is only 0.91 millimeters of bone. This is to be expected, and this is within the normal limits of bone resorption around a surgically placed dental implant. However, if a clinician puts a dental implant surgically into patients with other types of bone, there is increased risk of bone loss around dental implants. The natural dentition, the clinical probing measures do not always reflect the bone seen radiographically, but it is very clear that osteoporotic females are at risk for accelerated alveolar bone loss. What's the biological basis for osteoporosis patterns with on oral and IV bisphosphonate medications? This is also an illustration published in Implant Dentistry for the European Theater of Dentists, showing that osteoclasts and osteoblasts very, very carefully work together to enhance bone growth and maintain bone homeostasis. I published this with my colleague, my Ph.D. student, Professor Cameron Lee, originally from Shanghai, as shown in this picture. He practices now in Hawaii. Osteoclasts are primarily metabolic cells that take down bone, and in particular, the resorption pit is part of the normal process of taking down bone, where osteoblasts rejuvenate the bone and make new bone. This very careful turnover between osteoclasts and osteoblasts is required for optimum healthy bone. However, patients taking bisphosphonate drugs do have this potential of reversal of osteoporosis back to health, as illustrated here, or by scanning electron microscopy, a punch biopsy, bisphosphonates also have the potential of reversing osteoporotic conditions, as illustrated here. So in particular, let's focus next on the dental management of osteoporosis patients on oral and IV bisphosphonate medications. From Temple University, I published a systematic review and a meta-analysis showing the clinical impact on dental implant survival in patients taking anti-resorptive medications. For those of you not familiar with it, systematic review and meta-analysis are in particular those particular updates of the research literature that looks at the research published that impact on our patients. In conclusion, anti-resorptive medications, mainly bisphosphonate drugs, may significantly contribute to implant failure. Anti-resorptive medications, especially bisphosphonates, may reduce implant survival and impair the osseointegration of dental implants. Going one further, the systematic review also suggests that patients who have osteoporosis and take IV bisphosphonates planned for implant surgery should be cautioned of their higher risk for osteonecrosis of the jaw or even implant failure. These are examples of some of the IV bisphosphonate drugs that can be used by our colleagues in medicine to treat osteoporosis and other devastating bone conditions. What are some of the preventive strategies for osteoporosis patients on oral and IV bisphosphonate medications, and what can we do to reduce the risk? Well, we can also recommend that, however, in general, patients taking oral and IV bisphosphonate drugs have a distinct benefit to health and improvement of mineral bone dentistry. As dentists, we should never recommend discontinuation of these medications for any reason whatsoever. It's not our judgment to have patients stop bisphosphonate drugs for any reason, despite the fact that we need to govern their dental treatment. This is the article I published also with Professor Cameron Lee, originally from Shanghai, looking at the preventive strategies to minimize the risk of what is now called anti-resorptive osteonecrosis of the jaw. Scaling is what we recommend 7 to 10 days before the dental appointment of all the teeth in the dentition for a dental implant patient who is taking a bisphosphonate drug. In addition to scaling, reinforcing oral hygiene instructions, using a power brush, using manual brush, using irrigation devices, anything to improve the oral hygiene of our patients. There are many antimicrobials used in China, as shown in this slide. Chlorhexidine, 0.2%, with various manufacturers listed on this slide. The phenols and essential oils are another alternative. Also, cetylpyridinium chloride, or Crest Pro Health, povidone iodine, and hydrogen peroxide are also used as an antimicrobial rinses for our patient, both preventively for osteonecrosis of the jaw and also for treatment of osteonecrosis of the jaw. The antibiotics I recommend begin 1 to 2 days prior to the dental appointment for those patients taking bisphosphonate drug. The antibiotic of choice is amoxicillin, 500 milligrams, 24 tablets, TID, or 3 times per day. As shown in this slide, there are alternative antibiotics for those patients that are sensitive or allergic to penicillin products. The alternatives include metronidazole, ciprofloxacin, azithromycin, and cefuroxime. If you prescribe the alternatives to penicillin products, the dental clinician should also know the possible side effects of these alternative medications. One of the alternative medications that I like is azithromycin. Azithromycin is a macrolide antibiotic. It has improved GI absorption. It has an extended half-life. The minimum inhibitory concentration is lower, and it localizes infected sites. Generally, it's packaged up as a 6-tablet package. I recommend that patients take 2 of these packages. But how is osteoporosis diagnosed? It's diagnosed in a physician's office, and basically looking at the high-risk age groups, 13 to 18% of women over age 45 have osteoporosis. 47 to 50% of women over 45 have osteopenia. And once again, systemic osteoporosis is associated with mandibular osteoporosis. So the highlight is mandibles, follow the sequelae of skeletal bone. And we all recognize as a dental profession that osteoporosis is associated with increased tooth loss. Our colleagues in medicine make the diagnosis of osteoporosis using a dual X-ray absorptiometry, a series of 2 radiographs taken in patients at risk for osteoporosis. First, the X-ray of the spine is taken, and the density of the particular spinal X-ray is then converted and compared on a table with other factors showing normal, healthy patients. So this particular patient has the diagnosis of osteoporosis based upon the comparison of this radiograph to other standardized healthy patients. The second radiograph that is taken is a radiograph of the iliac crest and the femur. These particular radiographs are also compared to standardized charts, comparing the densitometric areas, and in this particular reading shows the patient is osteopenia. The physician generally selects the particular diagnosis that is elevated or the worst. So this particular patient, the diagnosis would clearly be osteoporosis. These are measured in T-scores. This is the diagnosis of bone condition. A T-score within 1 standard deviation of the norm is considered a healthy patient. A T-score 1 to 2.5 standard deviations of the norm is an osteopenia patient. A standard deviation of 2.5 standard deviations or greater is osteoporosis. Other medical conditions also are indicated for bisphosphonate use. In addition to osteoporosis and osteopenia, multiple myeloma, which is a cancer of plasma cells that affect bone, Paget's disease, which is the genetic disease of the bone, patients which being treated for breast cancer almost always are also put on a bisphosphonate drug. Men with prostate cancer and being treated with androgen deprivation therapy also are at risk for osteoporosis and also are treated by bisphosphonates preventively to prevent fractures. The prescription for osteoporosis for oral bisphosphonates are eledronate sodium and ebandronate sodium in China. The side effects of Fosamax, however, illustrate that can be complicated with different infection and local infiltration, often with delayed healing, and especially is highly prevalent in patients taking bisphosphonate drugs. You may also have learned that drug holidays may lower the risk of osteonecrosis of the jaw. According to the American Dental Association guidelines, first published in 2011 and reaffirmed many times since that time, stopping the patient taking bisphosphonate drugs does not reduce the risk for osteonecrosis of the jaw in these subset of patients. In fact, bisphosphonates have a half-life in bone of at least 11 years of time, and elevated levels of bisphosphonates in the bone occur with IV bisphosphonates. 142.8 times increased bisphosphonates with IV bisphosphonates compared to oral bisphosphonates. So the risk is much, much higher about osteonecrosis of the jaw in patients with IV bisphosphonate use. The IV bisphosphonate use approved in China are zoledronic acid, reclassed, and ibandronate. Zoledronic acid is used for multiple myeloma, neoplasias, and osteoporosis. Ibandronate is used primarily for osteoporosis. So these are drugs that you should be well aware of and indicated for dental surgery and proceed with great caution, or use other alternative means of more conservative invasive dentistry procedures if possible. The reclass for information for patients also is shown on most package inserts of the medications, that the patients are advised to avoid having any type of dental surgery while they're being treated by IV reclassed. This was the publication Professor Cameron Lee, originally from Shanghai, my Ph.D. student, and I published in Implant Dentistry. We placed dental implants in 4 patients taking zoledronic acid, and all 4 of these implant patients developed medication-related osteonecrosis of the jaw after implant surgeries. So therefore, oral anti-resorptive drugs, switching patients to IV zoledronic acid can be very, very risky for the dental practitioner. Let's take a look at the bone remodeling pharmacology and physiology. The occurrence of osteoblasts simultaneously with osteoclasts is normal in terms of development between the 2 types of cells in bone. Osteoclasts take down bone, osteoclasts build bone. But bisphosphonate drugs kill osteoclasts, thereby allowing the osteoblasts to build bone and strengthen the bone. And that's the purpose of these medications, to reverse osteoporosis and lower the risk of hip fractures in these patients. This artist sketch shows resorption does not occur with patients taking bisphosphonate drugs, and bone formation and mineralization are allowed to proceed. So therefore, the patient is much lower risk for osteonecrosis of the jaw and osteoporosis, and bone resorption and turnover do not occur with patients on bisphosphonate drugs. So the diagnosis of anti-resorptive osteonecrosis of the jaw for a dentist is the pain is variable in our patients. There's generally periodontal swelling, infections, frequently mobility of teeth, purulence, and exposed bone. The lesion may look something like this in the soft tissues, but osteonecrosis of the jaw is primarily a hard tissue lesion that frequently is seen on the soft tissues. Dr. Marshall Wade, an oral and maxillofacial surgeon, and I published this systematic review and clinical summary of different patients taking bisphosphonate drugs who suffered osteonecrosis of the jaw. You can see the different clinical appearances of these osteonecrosis of the jaw patients. So once again, accelerated bone loss and tooth loss in patients with osteoporosis only heighten the particular risk of these particular patients with osteoporosis. This is another patient more advanced, only 44 years of age with advanced osteoporosis combined with periodontitis. Already this patient has lost multiple teeth, and the remaining 4 teeth as shown here also suffer from about 50% bone loss around the dentition. It's a very rapidly occurring periodontitis in this patient with osteoporosis. You might also see widening of the periodontal ligament in these particular patients, as illustrated here, and also different types of risk factors appearing in the radiographs seen in the mandibular panographic film. So in conclusion, the questions that I answered in this part 1 of the seminar is, what is the biological basis for bisphosphonates with adverse outcomes? The biological basis is the decrease in osteoclast function, and in particular, killing osteocytes to permit osteoblasts to make more bone, disrupting bone homeostasis. The second question I answered in particular is, what is the proposed management? I recommended diagnosis is made properly, removing the bone spicules from the ONJ site, chlorhexidine rinses twice per day for 3 weeks, improve the oral hygiene of the patients, and especially trying to have patients use power brushes, interproximal cleaners, amoxicillin 500 milligrams 3 times per day for 30 days, and of course, monitor the patient at least bi-weekly. What are the dental preventive strategy patients? Optimal oral hygiene, power brushes, interproximal cleaning, prophy and a scaling 7 to 10 days before the invasive procedure, the chlorhexidine rinse for 7 days before and 14 days after the invasive dental procedure, and amoxicillin 500 milligrams 3 times per day, 24 hours before the procedure for the next 8 days. So in conclusion, once again, I extend my appreciation to BioRes BLC implant system, sponsoring today's webinar on osteoporosis and the impact of bisphosphonates on dentistry. In part 2 of our series of webinars, I will further enhance how osteoporosis is diagnosed, but I will elaborate on the medications, on bisphosphonates, and other preventive strategies, and take a look at other types of examples of the management of these particular types of cases. So osteoporosis is not to be taken lightly. Dental management of osteoporosis by bisphosphonate drugs and any other anti-resorptive drugs can result in osteonecrosis of the jaw. In particular, the BioRes PLC implant system can be successfully placed, as we can see in those 4-year patients that I presented earlier in tonight's seminar. So once again, BioRes is the system you can use in even the difficult to treat osteoporosis patients. Thank you very much for your time.